Welcome to Girls Gone Wellness, Dr. Rothwell.
Oh, thank you. I'm excited to be here.
Us too. If anyone knows me, they know that I am obviously very excited about this episode. It's been a very long time coming for a thyroid episode. It shocks me we haven't done one yet, but you have always been such a huge inspiration to me in this space, very much a role model as well. And so we're just really excited to have you on today and dive into the big topic of thyroid disease.
Yeah, and such a big topic, and I'm thrilled we get to kind of explore it on this level of detail. So
Yes,
hmm
definitely.
let's
Me
get
too.
started. Let's do this.
Let's do it. Let's start with having you introduce yourself to the listeners and let us know how you got into naturopathic medicine, but more specifically, the thyroid space.
Yeah, so I'm a naturopathic doctor and clinic owner. So I've been a naturopathic doctor for over 10 years now. Um, Naturopathic medicine was always part of our life when I was growing up. I had a very sick sister, and my parents did all the things. I was exposed to that a lot growing up. So it just seemed like a really natural choice to get into that type of medicine. For me, it just made sense with my own values. And then when I graduated from CCNM, I as you guys may relate to or experience to, like there's so much textbook knowledge, but once you get
Yeah.
out into treating people in the real world, a
Hmm.
lot of it there's so many gaps. There's so many gaps.
Hmm.
And specifically in the thyroid space, I was like, wow, the whole thing is a gap. It's like a
Yep.
black hole.
hmm
And I like puzzles. I like figuring things out. And so I was like, I'm just going to like go full throttle into this specific area. I'm going to figure it out the best that I can and put all the pieces together so that we
Mm-hmm.
as naturopaths and any clinician really have a really solid framework of how to diagnose, approach,
Hmm.
treat, talk to patients about their thyroid, like all of that stuff. So that's kind of been my mission since day one. Um, yeah.
Amazing. Yeah, as we'll get into the episode, obviously thyroid health plays a role in almost every aspect of the body, or I would say probably every aspect of the body. You guys know obviously way more than I do about this topic. But I think it's amazing that you've focused in this area because of course, like we all know as general practitioners a little bit about the thyroid, but I think it is such a big thing. So it's great that people can come to you if they do need more support in that area. So, I want to talk about what online or just in general people talk about having like a slow or a sluggish thyroid. So, this is like a very common thing that people will say or people will see. Many people see symptoms on the internet and then automatically think that they may have a thyroid problem, which I'm sure you see all of the time.
Yeah.
So, what would you tell us about someone that has like low thyroid function?
So, yeah, first off, you're totally right. I think when you look under like list of thyroid symptoms, like it's
Mm-hmm.
basically any symptom you could imagine, anywhere from like constipation to brain fog to rashes to joint pain to fatigue, hair loss, feeling cold. Like there's just so many. So anybody can look at a list of that and say, "Huh, I think it might be my thyroid," right?
Hmm.
Mm-hmm.
Um, in the vast majority of cases, it's not. There's so much overlap with those symptoms and other things. I would say the most common thing I see in my practice is that a woman comes in with a lot of those symptoms, but instead of a thyroid issue, she actually has low iron.
Hmm.
Which is a good answer because number one, it's usually easier to treat. It's not necessarily a lifelong condition, and it resolves a lot of the same symptoms. So the fatigue, hair loss, feeling cold, breaking brittle nails, like there's just so much overlap between those two things. Not only
Hmm.
symptom wise, but they overlap in terms of how iron helps our thyroid function optimally. So they are very much linked and intertwined in that way. Um, a sluggish thyroid, like that's not a term I use because it doesn't really mean anything specific.
Yeah.
I'm like, like let's figure out what that means. Like, is it we're talking about your thyroid hormones are changing? What thyroid hormones are we looking at to assess that? Is it based off of your
Mhm.
symptoms only? And then if that's the case, if they just come in feeling like their thyroid is sluggish, sure, we'll do thyroid testing, but we're going to do a whole lot of other stuff too.
Right.
Yeah, definitely. It's a difficult conversation too. I've learned through my clinic year, that we're not, like you said, we're not a textbook, right? So it's going to present differently for everyone. But
Yeah.
I worked with a lot of patients who dealt with obesity in my clinic year. That was the most of my patients. And I noticed that, I mean, we know that your TSH sometimes does sit a little bit higher when there's obesity. And sometimes I think in our space and in the wellness space in general, we have this idea of these like optimal thyroid numbers, which is great, but we have to also look at the patient, right? And
Mhm.
so I was seeing a lot of patients who were sitting in larger bodies were having a TSH of like 3, and that kind of functional mindset was like, "Oh, yeah, it's your thyroid. It's a thyroid problem." And we're like, "Oh, it makes sense, like the weight gain, the
Yeah.
fatigue."
Right.
But it doesn't, right? And
Yeah.
that's why I feel like this conversation today is so important because we think in the wellness space we know it all, but there's so many nuances when it comes to the thyroid, right?
Yes. So many nuances. And I think half my job is like myth busting a lot of things that are out there. I mean, you guys probably feel exactly the same way in this podcast, but is kind of breaking down some of these maybe older ideas that we had around thyroid or what we're testing, what we're shooting for, and being like, actually, like we have evidence at this point to suggest that's not the best way to approach it, and that
Yeah.
a TSH in a 70-year-old obese woman is going to be very different than our goal
Yeah.
TSH for a 25-year-old woman who's looking to get pregnant in the next year. And
Right.
both
Yes.
of those are different and both of those are okay, but we have
Mhm.
to be looking at it very individual.
Mm.
Definitely. Okay, I have to tell you guys a story quickly before we move on. So, Jeanette, you don't know this either, but a long time ago, I think it was before I started CCNM. Katie, you're actually the reason why I like the whole like myth busting space.
Oh, okay.
And it's because you actually called me out once in a very nice, polite way. But it was before I knew how to do research. And
Sure,
I had
yeah.
made a yeah, and I had made a post, pretending like I knew what was going on, and it was about herbs for the thyroid, and you had commented and you were like, "Oh, you know what? The research on that was only done in rats and it's really not that good." And from there I was like, "Shit, I really got to start looking into like how to do this research." So, I owe it all to you.
Oh my gosh. That is so funny. I didn't realize our relationship went that far back.
Yep, it did.
And I'm so glad it's come to such a positive place
It
versus me,
Mhm.
was.
just being a dick on Instagram. Because people
No,
are
it
like,
was a good thing.
like I can post what I want and you don't have to police my posts. And I'm like, listen, if you're going to spread inaccurate information that's going to
Yeah.
freak my patients out, I think I
Mhm.
do kind of have a right to say,
Yeah,
just so
100%.
we're all aware, like that might be your clinical experience or your belief, but that is not what we see, in the
Yeah,
research. And we can all have our own ideas, but it needs to be very clear where those ideas are coming from. If
for
it's
sure.
yeah,
coming from the medical medium and powers above, like let's just make that clear, right?
yeah.
And if it's coming from good data and good research,
Mhm.
let's also make that clear.
Mhm.
Absolutely. Yeah, I just thought it was so funny.
That is actually hilarious.
I love it. Okay, so let's get into Hashimoto's a little bit
Sure.
because I think there's a lot of people think that like, Hashimoto's is the same as hypothyroidism and it's different, right? So I want to talk a little bit about Hashimoto's. What is it? Is it the same as just having a low thyroid? Let's get into that conversation.
Yeah, so two, I would say like two very different conversations. if we're looking at just hypothyroidism versus Hashimoto's hypothyroidism, with Hashimoto's, it is an autoimmune thyroid condition. So, what that means is that our immune system, for whatever reason, is targeting our thyroid glands specifically. It's creating inflammation, it's creating cytokines, all these different immune cells. It's breaking down thyroid tissue. And our body, in turn, is making these thyroid antibodies. So, that whole process of having an immune response, chronic inflammation in the thyroid, and a destruction of thyroid tissue eventually is
Hmm.
what drives that whole progression of Hashimoto's disease. Very different from a just hypothyroid, which honestly, I almost find hypothyroid without Hashimoto's to be more of a head scratcher because we have
Yeah.
to really put on our thinking caps and be like, okay, what's causing it in this situation? Like, is it a nutrient deficiency? Is it poor digestive health? Is it, something that they're not getting that their thyroid needs? Is it other
Hmm.
hormones at play? Like there's just such a long, long list of things to go over. Um,
Hmm.
but with Hashimoto's, we have a fairly clear idea of what's causing the thyroid issue, and we have, I think, at this point, some really good tools at treating it as
Yeah.
well. Yeah.
Mhm. Bear with me when I ask these questions, but
Yeah. No,
is it
please.
true is it true that many cases of hypothyroidism are actually autoimmune in nature? Um, like, and does this change the treatment?
Yes and yes. So,
Okay.
yeah, the vast majority of hypothyroid cases, especially in women, especially in North America, are Hashimoto's. Like it's like 95%. Like it's
Okay.
rare for me to see somebody, especially overtly hypothyroid, where that is not immune related. So the
Okay.
vast majority of thyroid patients have an active Hashimoto's or have had it in the past.
Hmm.
Um, and it does change completely the way that we would approach it. For me, conventional treatment, it's going to be the same. So this is
Right.
where
Hmm.
patients can get a bit confused and a bit frustrated because no matter what type of hypothyroidism they have, conventional medicine is going to wait till the TSH reaches a certain tipping point. It could be 6 for some doctors, it could be 10. And then they're going to initiate a thyroid medication. They're going to take that medication for the rest of their life, maybe change their dose every few years, but that's basically the beginning and the end of management. And that's the tools that they have. That tool works really
Hmm.
well, but it's not all that we do it, all that we can be doing. So in
Hmm.
Hashimoto's, in my practice, there is such a larger focus on treating that autoimmune disease,
Mm.
decreasing inflammation, decreasing that tissue destruction locally in the thyroid, improving the health of the thyroid tissue, ideally regaining good thyroid function, and
Hmm.
seeing a slow but a significant decrease in thyroid antibodies over time.
Hmm. It always blows my mind. I guess it makes sense, but it does blow my mind how so many patients they don't know if they have Hashimoto's. That's what I noticed. They came in, they're like, I don't know. Like nobody told
No
me. Nobody
idea.
Yeah.
tested for it.
Yeah,
I'm like,
no,
what?
and no,
But
and this is, yeah, they're like, well, why, like, I don't know, like, my doctor didn't test it, my endo didn't test it. And
yeah,
I mean, it's because it's not going to change their treatment plan. Whether or not
Right.
you
yeah,
have Hashimoto's, it's not going to change what they're recommending. They're still going to recommend Synthroid or Altroxin, like some version of
yeah.
levothyroxine, and it's not going to change any other part of how they treat you.
Hmm.
Which I think is a very like narrow lens to take,
Yeah,
especially because we know that in Hashimoto's, those antibodies not only impact the thyroid, but can impact other body systems. So
yeah,
we can see that there's this like ripple effect, right? If you have
yeah,
Hashimoto's, you may be more likely to have other autoimmune diseases. You may be
yeah.
more likely to be celiac. You may be more
Hmm.
Hmm.
likely to have fertility concerns or miscarriage. And none of these are
Yeah.
guarantees, but it's that ripple effect that I think we need to take a step back and look, with a wider frame and see all the different things that this could impact in someone over the course of their life.
Absolutely. I think this is a good segue into the conversation about lab work.
Yeah.
I feel like we have two ends of the spectrum. So we have the conventional side where often it's only a TSH, whether that's diagnostic or whether it's like following up.
Yeah.
And then we have the functional side where it's a lot of like you need a full thyroid panel every 3 to 6 months.
Every 3 months.
Mhm.
And I'm like, can we like maybe meet in the middle?
Meet in the middle a little bit. Yeah, I totally agree. I was thinking this the other day and like thinking about our conversation, and I was writing an Instagram post and I was like, man, like the thyroid space really does live in like two very different ends of the spectrum. And I think
Hmm.
because it was something that's in a lot of people's minds, so there's so many gaps in the conventional space, we have overcorrected so much that
Hmm.
there is so much over testing and over treatment happening in
Yeah.
other areas of the space. So I really am like trying to like nourish and create that in the middle
Hmm.
balance, which is not sexy or exciting, but like that's where the magic happens. So
Yeah.
yeah.
Yeah, absolutely. When it comes, sorry, Jeanette. Jeanette is writing in the Google Doc because she doesn't know what's going on, and she's like, "Why is there so many antibodies to test?"
I feel like, okay, as someone that like knows just what we were taught in school, honestly, on thyroid stuff, our education on thyroid health is like minimal. And Vic, you can attest to this too. And
Yeah.
it's really unfortunate because like I would have patients in the clinic that had all of these concerns and like I had a little bit of knowledge, but I did feel like my knowledge is lacking. So I mean,
Yeah.
I'm learning, so don't mind me
I
asking all these
mean, you
questions.
are the vast majority of interns when they come out, for sure, and the vast
Yeah.
majority of grads. That's how I was. That's how I felt. I had a
Mm,
Graves patient in my clinical year, and like I had zero clue what to
Yep.
do. My
Hmm.
supervisors had zero clue what to do. Like I was just like,
Yep.
I don't know what to do. I don't even know what these antibodies mean. What's happening for
Hmm.
this patient? Like I wish I could go back and like share with this woman all the wonderful knowledge that we now know,
Yep.
but
mm,
you can only do what you know at the time,
yeah.
and yeah, go from there.
Mhm.
Exactly. I feel like our whole year is going to be listening to this episode because they're like, "Please, someone help me with the
Please help
thyroid."
us. And
Yeah.
this has been like one of my deep missions, right? Because I had to
Hmm.
create it for myself. Like I had to do the research, and I went to every conference, good or bad. Most of that information I don't even reference anymore because like
Yep.
I've flipped to completely the other side. But like I did it all over the course of 2 to 3 years in terms of thyroid education. Like if it was
Wow.
out there, I found it. And then
Hmm.
was using that in practice, and I was like, well, they're still not doing any better. So then I went back to like ground level and started reading a lot of research and a lot of studies, and that is what changed my practice, and that is what
Hmm.
changed how I want to create these systems for future generations and not make it so hard.
Yeah.
Mhm.
It is a shame because there's so much we can do, like, and the research does really support it. So it's weird that, like, we're still very much being taught that old model, if
Yeah.
anything, right?
Yeah.
Like, I don't know. Well, we don't have to get into the whole thing, but it's definitely a concern. Like, the things we learned are a bit concerning.
Yeah.
I'll be honest.
Mhm.
What is your take? So when we look at the thyroid panel, I'm thinking so we have like our TSH, we have our T3, T4, free thyroid hormones, we have our antibodies, so our TPO and our TG antibodies, and then we have our reverse T3 that people like to throw in there too. So I
Yeah.
want to ask like what is relevant,
Sure.
and then we have to talk about our T3 too.
Absolutely. So, I mean, they all are potentially relevant. Um, However, lots of nuances and context to provide. Like, if someone hasn't had, let's say, someone hasn't had their thyroid tested for quite some time, they have no history of a thyroid issue. We just kind of want to get a sense of what's going on. Um,
Mhm.
we're not necessarily suspicious of any thyroid issues, I would do what I call a thyroid screen, which is
Mm-hmm.
TSH and TPO and TGAB. So those are
Okay.
two antibodies, thyroperoxidase antibody and thyroglobulin antibody.
Mm-hmm.
So in with those three tests, we are going to pick up presence of any thyroid autoimmune conditions and the most accurate test in terms of picking up overt thyroid dysfunction. So if all of those three are like super happy, no issues,
Mm-hmm.
like I think we can pretty much move on to other things.
Hmm.
Right.
There's going to be some caveats to that, of course. Like if someone's coming in with a wealth of thyroid symptoms, maybe they're already on a medication. I would
Mm-hmm.
usually do the full thyroid panel. So TSH, free T4, free T3, and both of those antibodies, especially if they've never had them done previously.
Yeah.
I also love to see thyroid ultrasounds. This is a little bit harder to
Yeah.
always get done, but it's another way to either confirm or rule out Hashimoto's. There is a small
Mm-hmm.
percentage of people who are seronegative Hashimoto's. So even though they have tissue changes and tissue destruction in their thyroid gland, their body does not make those specific antibodies.
Hmm.
So if we only test them on blood work, we'll say, well, it just looks like hypothyroidism, like we don't see any Hashimoto's. But when we dig deeper, often these patients have like a strong family history, they have
Yeah.
PCOS, and then, maybe some trouble with fertility, like other symptoms suggestive of Hashimoto's. And we look at
Mm-hmm.
their ultrasound is like heterogeneous tissue texture, couple small nodules indicative of
Yeah.
thyroiditis. So we're seeing it in the tissue but not in the blood work. So that's like my fail safe. Like
Interesting.
if there's still a question of whether people are Hashimoto's or not, then I would add on that ultrasound because we can see a lot in just what the tissue is looking like.
Definitely.
Yeah, yeah, and
Mm-hmm.
I
I.
I
Mm-hmm.
I for the most part don't test reverse T3.
Yeah.
Um, unless patients like really want to have at least one reverse T3 on their lab test. Like if they've like, I've never had it tested before, I really want to do it. We talk about the
Mm-hmm.
pros and cons and the limitations.
Mm-hmm.
Like I'm not gonna like hold it behind lock and key, but I'm not
Yeah.
standardly running it for most patients,
Okay.
Mm-hmm.
which is probably I'm probably on the outskirts in terms of the functional medical uh, space on that. But the reason for that is that, and this is one of the myths that I have an issue with, is that the that reverse T3 can block T3,
Right.
and you guys may have come across that before. I made an
Mm-hmm.
Instagram post in my early years about reverse T3 blocking T3. Like,
Oh
we're
no.
all, no one's innocent here. We've all done
I'm sure I did too.
it. And this is coming from, again, a lot of functional medicine, like doctors and blog posts
Yeah.
and things like that. It's
Right.
just someone picks it up and it just becomes pervasive, and it becomes, the expected or expectations that this is what it does and this is what we have to test. So while I was going through again, I was like, I'm going to do a deep dive on reverse T3, see what I find. There is really no good data or research to suggest that reverse T3 would ever block T3. It basically, if reverse T3 and T3 are in the same cell, a T3 hormone is going to bind at the strength of 200 times more than a reverse T3.
Yeah.
So the thought that a reverse T3 would instead bind to that nuclear receptor and prevent T3 from doing its job is very, very unlikely.
Yeah.
Okay.
When we
Mm-hmm.
might see reverse T3 being elevated is most commonly if people are over medicated on T4, then
Yeah.
it's being used as like it's a way to get rid of excess thyroid hormone, essentially. So most
Mhm.
commonly when we're over medicated, I see it being elevated, like almost like that's the most common reason why I see it being high.
Mhm.
We can also see it being high in more acutely chronic illness, like hospitalized patients.
Right.
Because in that situation, our body is under a lot of stress. It's trying to preserve energy, slow down our metabolic rate. So then it's shuttling more T4 to reverse T3 to do that.
Okay. I have a
Everyone up
question
to
that.
date on their biochemistry.
Yes,
Yeah.
I was gonna say, it definitely seems like something we're gonna get quizzed on our board exams. So, I do have a question that I've been thinking about through our conversation, and something I've heard online and through podcasts as well. Do you
Mm.
think that thyroid issues or hypothyroidism is becoming more common nowadays, or do you think people are testing more? Because you hear like, our environment is getting more toxic and people are having thyroid issues and like all of these things. I would just love your take on that.
Yeah, I mean, it has been levothyroxine has been one of the top prescribed supplements, if not supplements, medications, if not the top prescribed medication for a long time. Like
Okay.
it has always been something that is fairly common, especially
Mhm.
as we age. I think most people will say, yeah, my grandma's on thyroid medication,
Yeah.
or my grandpa's on thyroid medication. Um, the link between is Hashimoto's becoming more popular? It's a great question. And like, I don't know. I don't have the answer to that. I think we are testing more for it.
Mhm.
So more people are aware of the fact that they have it. We're understanding more about the other risks of Hashimoto's and the long term impacts of Hashimoto's. So I think it's likely, due to more of an awareness for sure. Could there be environmental things that are adding into the picture? I think that's very likely too, right?
Mhm.
But I don't have any good data or like brilliant ideas on like how much is playing a role in one way or another.
Yeah, for sure. Just always thought about that. I hear a lot about that online, so thought I would
Yeah,
ask.
yeah.
Of course, we know the thyroid plays a big role in every aspect of our body. So, is there any other blood work that you would check for people, like cholesterol, blood sugar levels, other nutrients? What else are you running if someone comes in with like a
Yeah,
thyroid issue?
yeah. I mean, it can be a laundry list because, as you said, it can impact so many different body systems. But I do check for nutrient deficiencies. So, low iron, low B12, those are more common in those with Hashimoto's and hypothyroidism. Low vitamin D as well. So, that's always on the docket, especially if it's autoimmune related.
Right.
I would, when testing iron, both ferritin as your iron stores and an iron panel. Ferritin may not be as accurate as we want it to be in any sort of inflammatory condition. So we really want to have the iron panel alongside that to get the most accurate look. Um, also do pretty thorough metabolic screening. So cholesterol levels, as TSH rises, cholesterol goes up too. Literally on
Mhm.
a graph, they go like this. So
Oh.
they're very, very closely linked. So testing, obviously looking at like total cholesterol levels, but also triglycerides and HDL to get a sense of metabolic health, and as well as your fasting glucose and HbA1c. Sometimes adding in fasting insulin if we know that there's a weight component to their concerns. I
Mhm.
do like to screen for other autoimmune conditions if needed. So sometimes that will look like our general inflammatory markers. So CRP, ESR, ANA is a nice umbrella one to catch anything like lupus related. Um, and then I do like if I had a magic wand, I would test every autoimmune thyroid patient for celiac. So
Mhm.
uh,
Yeah.
that would be on my wish list, absolutely.
Mhm.
And then basic um, function tests in terms of liver enzymes, kidney function, like just kind of the
Mhm.
basics. But those would be the priority ones from a
Yeah.
thyroid perspective. I don't know. Did I miss
Okay.
anything on a lab requisition? I think that's basically every
I was gonna
test.
say, I think that's like the
I
whole
think
lab
that's
rec, yeah.
it.
No, it's interesting to me about the whole cholesterol piece because I'm just thinking like if a patient, I don't know, say if you're doing routine lab work and maybe they're not testing like a TSH on your lab work, but you have high cholesterol, like that's interesting to me. Like would that be something that maybe someone should look further into like thyroid testing if like you're metabolically healthy but like your cholesterol is high for some reason? I'm just thinking.
Definitely. Definitely. So if you
Okay.
have high cholesterol, especially if it's unexplained by, diet and lifestyle factors, it's not genetically running in your family. I would certainly test TSH as a follow up test if it's not been done already.
Okay, cool.
It's interesting though, because I feel like in younger people, we're not really testing cholesterol that often,
Right.
right? So we would miss that, unfortunately.
Yes.
Okay. So when a patient, let's say you have a patient that has hypothyroidism, they're on medication. Let's say they have Hashimoto's. They're on medication. They come to you. They're dealing with fatigue. They're
Yeah,
dealing with weight gain. They're dealing with hair loss. Those are the three I always see.
definitely.
Their TSH is normal.
Okay.
What do you do next? A case
Aside
study.
from like the full gamut of blood work that I just recommended, like as a starting
Yes.
point, and
Mhm.
their TSH is what? What normal are we
Ooh.
talking
Okay. Their TSH is 2.8.
Okay, all right. And how old's this person? This imaginary
They're
person?
29.
And I'm assuming they have high antibodies.
Yep.
Okay, making it up as we go. Okay, so here's my like general framework. So one is to identify and treat any nutrient deficiencies. If
Mhm.
they have iron deficiency, if their vitamin D is deficient, like that is going to make a huge difference in
Mhm.
energy, hair loss, weight, like all of the things. So
Yeah.
that's like our lowest hanging fruit that I'm like, let's start there, identify those, and treat as needed. Second would be to look at optimizing hormone levels. So, if let's say their TSH was out of the normal range, and here I can get a little bit pickier, like if they're
Mhm.
already medicated and generally like young person, I do like to see that TSH between 1 and 2.5. I would say a
Mhm.
lot of my patients do report that like 1 to 1.5 is often the sweet spot where
Yeah.
they feel like at their best. So that might be another part of the conversation is like how we want to optimize that. Are we going to
Mhm.
start through, specific supplements, which we can talk about, or do we want to modify their medication plan in any way, shape, or form? Increase their current medication, add on another medication. And
Mhm.
we have that I have that conversation so much of the time.
Mhm.
Um, Often what we're doing is starting with the increasing the supplements and then treating the Hashimoto's and seeing if we
Yeah.
can just get that TSH back into that sweet spot with those
Mhm.
treatments. Um,
Mhm.
Even um, treating an iron deficiency will often optimize the TSH.
Yeah. Yeah.
And then the antibodies, just on their own, even if your TSH is perfectly normal, those antibodies can cause symptoms all on their own. So they contribute
Yeah.
to fatigue, hair loss, anxiety. Those are the most common ones we see in the literature. But
Mhm.
as you guys probably know, every patient tends to experience things a little bit differently. So
Mhm.
treating those antibodies is like the long term, right? We want to, over the course
Mhm.
of 3, 6, 9 months, see hopefully a reduction in those antibodies. So it's a bit of like a staggered approach, and certainly all
Yeah.
doesn't happen overnight. But the goal is that we can get TSH happy, antibodies happy, nutrients where they should be. And in
Mhm.
my experience, most people do wonderfully with that type of approach and do
Yeah.
notice a substantial difference in their symptoms.
And we're going to talk a little bit soon about weight management, but I think probably a good time to highlight too how, like, if you have a normal TSH, but you have the antibodies, and maybe one of your symptoms is fatigue, it's going to be
Yeah,
harder for you to lose weight when you're tired. Right. And so it's like the
absolutely.
downstream effect of just one symptom can cause all the other symptoms to
Mhm.
worsen as well, even depression and
Absolutely.
mood. And right. So it's that
Yeah.
piece too. And I think we forget a lot of the time that it's not just the TSH, that antibodies matter when it comes to
Yeah.
symptoms too.
Absolutely.
Right.
Yeah. It's very similar, I would say, to my patients who are going through perimenopause and
Yeah.
they're not sleeping well. They feel like shit all the time. They've got
Yeah.
cravings. They're tired, irritable. They're not doing their
Hmm.
exercise. They're eating like not their standard fare. And they're like,
Yep.
yeah, and I'm gaining all this weight. And I'm like, yeah, that makes
Yeah.
sense. Like, you feel like crap. And it's really hard
Yeah.
to eat well and exercise when we're not feeling good and when we're not sleeping and feeling
Yeah.
like we have proper energy levels. It's very much like that. But in the thyroid space where it's like, yeah, you
Hmm.
feel crummy, like you feel tired, you may be not getting the exercise you need, you may not be meal planning and doing those types of things. So, some of that weight loss or weight gain can come from exactly that. It's not always tied
Yeah.
directly to the thyroid hormones, but as like a downstream effect of just kind of feeling shitty.
Mm.
Yeah. Definitely. Okay, we're going to get more into that in a second, but I do want to talk about medication.
Yes.
So we have levothyroxine.
Yeah.
Obviously, there's a few, but we have levothyroxine and we have natural desiccated thyroid, and there's a war that one is better than the other. And I want to talk about these meds. Like, is
Mhm.
one better than the other? Do you like to start with the levothyroxine? Like, how do you kind of work through this conversation with patients?
Yeah, I would say, again, I'm like a meet in the middle kind of person. I do not work in the extremes. So I do not
Hmm.
believe that one medication is inherently better than the other. There are ups and downs to both of them.
Yeah.
Levothyroxine, most widely available. All
Hmm.
doctors are going to be prescribing that medication. The
Hmm.
NDT is a little bit more in the functional medicine space. Like a GP is not going to out of the gate prescribe that type of medication. The main difference between the two of them is that levothyroxine is just T4 and
Yeah.
NDT has T4 and T3. So, pros of NDT are that a lot of people with a combination medication, and by combination I mean contain both T4 and T3, a lot of people do find that their thyroid symptoms improve with that type of regimen. This
Hmm.
is more likely in patients who have had long-standing hypothyroidism, a thyroidectomy, radioactive thyroid. So if the thyroid tissue itself has been severely compromised, we find those patients often feel better on the combination.
Hmm.
Lots of regular hypothyroid patients who don't have those things also do, but we just find the
Yeah.
effect is a little bit more in those populations. Downside
Hmm.
to the desiccated thyroid is it does have a higher rate of side effects. It
Hmm.
is harder to manage as a practitioner when we're talking about dosing and
Mhm.
lab management and making sure that this is something we're prescribing safely for our patients.
Yeah.
Um, which I mean, that could be a whole other a whole other
Yeah.
side topic that we can talk about.
Hmm.
Um, so those are kind of like the pros and cons of the desiccated thyroid. I think any personally, I don't think that the fact that natural desiccated thyroid has the word natural in it, I don't think that natural always means better. I don't think that that's the reason why. I think that it's largely because it contains both the T4 and the T3. And for a lot of
Hmm.
people, that makes a difference. And we do see that
Hmm.
reflected in the literature. When we move people over, most of them feel better. Hmm.
Hmm. Definitely. I had that experience for sure with
Yeah,
desiccated thyroid. It was a game changer for me. But I always
totally.
tell patients, like, if you feel good on Synthroid, oh my gosh, if I could go back to paying $16 for my levothyroxine, I would.
Right?
Mm,
Yes.
Like,
Yeah.
yeah, seriously. So the
Yes.
accessibility thing sucks. It's funny because I
Yes.
had a conversation with my GP recently, who's wonderful, and he said to me, he's like, "I'm going to be honest with you. I don't know how to prescribe desiccated thyroid." He was like,
Yeah.
"Nobody really taught us how to do that." He's like, "If you need it, I'll look into it. Like, if you need me to do it." I'm like, "It's okay. I'm good." But it's just the reality, and I think it's nice when a practitioner could admit to that. Right?
Definitely.
Like, we don't it's not super talked about, which is
Yeah.
unfortunate because
Because
it's an
most
amazing
GPs in that
medication.
situation would be like, we don't use that. It's not safe. It causes too many issues. There's no way I'm
Yeah,
prescribing it. So that's so wonderful to have someone who's like,
yeah,
if that's working really well for you and your levels look great, like I'm happy to facilitate that.
yeah,
But there are a lot of pros to levothyroxine, right? Easy to get
yeah,
prescribed, very inexpensive.
yeah,
And often, we see less side effects and can be
mhm,
safer in certain populations.
yeah,
So,
mhm.
definitely escalating age, if there's any heart arrhythmias, osteoporosis,
mhm,
fertility, pregnant patients, those are all
yeah,
categories where it'd be like, look, I think the levothyroxine is actually a better fit for you right now. We can always revisit it. Um,
mhm,
but there are some situations where that is what I recommend to people, and a lot of people aren't aware, but you can take both of them. You can take
yeah,
levothyroxine and desiccated thyroid at the same time,
Hmm.
and I actually
mhm,
love that combination because a lot of the issues we have with the desiccated thyroid comes down to the fact that the ratio of T4 to T3 is so different from our natural physiology. It's a higher T3 than our body is really used to coping with or experiencing. So it can cause more easily like a suppressed TSH and high T3, heart palpitations, like just feeling like there's just too much T3, especially at higher doses. But when
mhm,
we combine both together, we can really get into that sweet spot of like an
yeah,
8 to 10 ratio between T4 and T3, which is what our body's
mhm,
really more used to.
yeah,
And I would say that is the best way to see a thyroid panel that is most similar to a non hypothyroid healthy patient.
wow,
Wow, that's
mhm,
fascinating. I actually just well, not just, but I did my prescribing exam back in April, and I remember when I was flipping through the CPS, like, and I got to the thyroid chapter, like Synthroid or levothyroxine was the only one that was listed, like,
Yeah.
and DT isn't in the chapter, like, it's not there at all, which is so fascinating. I'm like, but you're telling me if I get my license, I can prescribe this, but it's not in the book. I'm
Like,
like,
I'm going to
what
give
is
you
happening here?
this here. Like,
Yeah, I'm
yeah.
like, okay, so weird. I know I texted Vic and I was like, am I missing something? This is not in the book, but
No,
here we
you're
are.
not missing anywhere. So yeah, that's the other thing. Like we got access to this medication and nobody knew how to prescribe it.
mhm,
So that was another thing that was really important to me to kind of give people a resource where starting
Yeah.
from scratch, you have everything you need to safely prescribe in practice, have these conversations with your patients because it's not a panacea. Like it's not not the answer to everybody's problems all the time.
yeah,
And you can go wrong
mhm,
with it.
oh,
It can
yeah,
cause side effects and it can cause long-term risks. So we do need to
mhm,
know and have a deep understanding of how that medication works. They
yeah,
use so small history lesson.
yeah,
Before we had Synthroid, so that was made in the lab
mhm,
synthetically in like 1970s. But prior to that, desiccated thyroid was the treatment for
yeah,
hypothyroidism, but it was
Hmm.
at a time where like it was not regulated, it was not quality controlled. So what people were getting in terms of dosing from pill to pill, from bottle to bottle, were like all
mhm,
over the place. Lots of side effects were seen. So when
Yeah.
we developed this really stable, well-controlled level of thyroxine, it was like the holy grail of medicine, right?
Yeah.
We could keep people's thyroid levels stable. So you can understand
Mhm.
why the conventional system was like, we don't need that anymore. We've got
Right.
this. Like, this is going to be the
Yeah.
best thing.
Mm.
But
Mhm.
now we've kind of come back to it as, and in more modern times, right? It is a Health Canada approved drug. It goes through quality control. Like we don't have those same um, concerns with it as we would in the
Yeah.
1950s or 60s. But those are the messages that are still taught
Yeah.
through conventional medical school. So profs
Wow.
will be like, it's the dose is inconsistent. It's like a Russian roulette of how much you're getting.
Yeah.
That's still a lot of the messaging that's coming out around it. So
Hmm.
Mhm. Well, I will say though, there is like still a black market for it. There's still like
really,
I don't know. I know somebody in the UK who had written to me on Instagram and their doctor wouldn't prescribe it and they were ordering it online.
Oh
oh yes,
no.
oh I know, it's
I
awful.
was like, "Oh,
Like
no."
yeah, that there's I've seen a couple things. Like someone was seeing an ND in Italy, and she was getting it from Thailand, I think, and shipping it to
Yeah.
patients, and it was costing like
Oof.
$500. And like, I mean, you get a medication outside of the country, like you don't know what's in it at the end of the
No.
day. You're
No.
No,
not
any
quite
medication.
sure what's going on there. So I really avoid
Yeah.
any of the like desiccated thyroid, even like on the supplement end of the market,
Yeah. Mhm.
anything that has that in it, because often one, that we don't know the dose, and two, there can be active thyroid hormone in there.
Ooh, yeah.
So I
That's
had
freaky.
one patient taking one of those thyroid glandulars,
Yep.
itching like 6 a day, and she's like, I'm feeling like really jittery, and like she was like heart palpitations, and like we looked at her
Yeah.
blood work, and like she was hypothyroid, like off of a
Yeah.
supplement she ordered from the States.
Mhm.
Wow.
So like
Yep.
none of that through me.
No.
Mm-mm.
Mm-mm.
No, I
If
don't
you
like
want to give
that.
me thyroid medication, I will prescribe the safe form, the right dose, and treat you properly. Like, let's not
Yeah.
go on the black market and try to
No.
get our
No.
own source.
Mm-mm. No, I always tell the story. I took at one point an adrenal glandular and like it honestly, I thought it was going to ruin my life. I became like I couldn't stop taking it. Like I felt like I don't know if it was placebo, but I felt like I had so much energy, so I kept taking it to the point where I was like it was actually getting concerning. And then I was wondering like what even is this? Like this can't be safe.
Yeah, yeah.
I always
You
have
wonder,
weird
like,
supplement stories.
I mean, I wish we could have tested your hormones while you were doing that. Like, maybe they did thyroid hormones in there, right? Like, if it's
Who
adrenal,
knows?
like, bovine, or who
Yeah,
knows? But yeah,
that's what it
you're
was.
right. Yeah,
Mm-hmm.
wild,
So
wild
scary.
west world of
Yeah, yeah.
supplements sometimes.
Okay, let's move to the weight management conversation. Obviously, this can be an episode in and of itself, but
Yeah,
we'll try to
yeah,
keep it just like high level. We know that people with hypothyroidism tend to struggle with weight gain.
yeah,
And it's a really interesting conversation because the basal metabolic rate differences aren't as drastic as maybe we might have once thought.
yeah.
Um, Tell us, is it really harder to lose weight with hypothyroidism? How do you have that conversation?
It's just I feel like it's such a firmly held belief in the
Yeah.
community and person to person. It's almost like a self-fulfilling prophecy for some people. And I'm not suggesting they're doing it to themselves, but when we have that concept of like, I have hypothyroidism, it's going to be so hard for me to lose weight. And that's like how we're
Yes.
setting out to start. It's really hard. Like, that
Hmm.
mindset makes a difference, and that belief that you have a condition that's going to limit
Mm.
your goals
Yeah.
is an issue. So I'm often like having that conversation in terms of like not necessarily challenging that belief, because for a lot of people that's the reality, and like patient to patient, right? Everybody's going to experience it differently. But
Hmm.
there are just so many other things that can be at play. So like the BMR differences are maybe in like the what 200 calories. Like it's not a lot. It's not a lot.
Mm-mm.
And in studies that we've tracked weight, and we've looked at when we give someone hypothyroid and we give them thyroid medication, the weight loss is like very minimal. So for
Yeah.
people who are like, I think I have a thyroid issue, I've been gaining weight, and they're like, I think if I
Mm,
just start a thyroid medication, I could be able to get this weight off. And that is usually
Mhm.
not the case.
mhm,
If anything, it's like the last thing that might happen after we correct so many other things and do a lot in the diet and lifestyle space, and
mhm,
just
Mhm.
metabolic recomposition, basically. Um,
Mhm.
it is such a complex area, and like I personally have like shied away from a lot of weight management in practice because I find it to be another like complex area where I don't feel like we have enough good answers. I don't feel like I have a good framework. So this is like
Mhm.
my next puzzle that I'm starting to work on figuring out. So like in a year,
Mhm.
I'll have much better answers for you guys.
Yeah.
But yeah, our current understanding of it is that it is a very minimal, and any weight loss we do see when starting thyroid hormone is water weight,
Right, yeah.
Yeah.
water retention,
Yeah.
and water weight.
Mm,
So I think
yeah.
that, I mean, all of those studies are on levothyroxine. So I do wonder,
Mhm.
like, could that be different if we're using a combination approach? Maybe,
Mhm.
maybe.
Yeah.
But
Mhm.
I think a lot of it comes from like, let's get you feeling better,
Yeah.
and so that you can do the work around weight
Yeah.
management and go from there.
Mhm. In my experience, when I was really dealing with it, I mean, I had gained like 20 pounds in a short amount of time. But when I look back now, like I was dealing with depression, I was dealing with fatigue, all of the other things, right? And when I had started desiccated thyroid, I had also done a million other things for my health, right?
Yeah.
Working with an ND, you're never doing one thing at once or at a time.
Yes.
And so I had lost the weight, and I had always said it was because of my medication and it was because, desiccated thyroid helped. But really, when I look back, it was probably one, I had someone who believed me and listened to me, and that motivated me. And
Yeah.
two, the fatigue was pretty like just with a couple of changes, my fatigue improved drastically. And then I was able to walk more, and I was back in the gym, and I was motivated, and I was excited. And then
Yeah.
you eat better. And it's that downstream, right?
Absolutely.
Makes a
Like
big
I often
difference.
get asked like, how do you address weight loss in a thyroid patient? And I'm like, kind of like how we address weight loss in any of our patients. Like
Right.
it's
Yep.
like,
Mhm.
yes, of course, we want to look at those thyroid hormones, and if they're like vastly out of range, we want to
Yeah.
support that because that is going to make a difference in terms of how they're feeling overall. But all
Mhm.
of the same principles still apply. Like I don't think there's
Yep.
anything extraordinarily special or magic that we do for thyroid patients that's different from what I would do with one of my other patients with
Yeah.
Mhm.
weight loss as a goal.
Mhm.
Mhm.
I'm glad that we touched on that.
Yeah, yeah,
Okay,
I'm
I
not a
wanna touch on s sorry.
fair.
I wanted to sorry, I wanna touch on supplements. So we hear a lot about iodine, and then there's
Yeah.
2, like, sides of the story to iodine as well, so I'd love for you to
Mhm.
touch on that, and then there's selenium, zinc, and inositol, there's a whole bunch of herbs as well. There's also,
Yeah.
like I mean, there's a bunch of, thyroid, like, combination products as well, so I'd love for you to touch on those, but yeah, what supplements do you use?
All right. So I'll start with like the good ones, the ones that I use and I love. So vitamin D
Yeah.
we've already talked about. There is a lot of research on vitamin D, especially in Hashimoto's. So we see lower levels of vitamin D in people with Hashimoto's, and when we treat their vitamin D levels, their antibodies come down and their TSH
Mhm.
improves.
Yeah.
We see other changes in terms of like some of those biochemical, cytokine inflammatory markers as well. But those are really the big things that we're looking at. Same thing with selenium and inositol. So both of those also have been looked at in the research over the course of 3 to 6 months. That's usually the extent of any of the studies. There's none, no longer term ones that I'm familiar with, at least, and I would be. So with both of those, we see a basically a reduction in inflammation in the thyroid gland. So those cytokines are turned down, the thyroid tissue improves. If there's nodules, those can improve. So, in response, antibodies are generally responding in about 3 months, but definitely by 6 months.
Mhm.
Um, so, those three would be like the basics of any comprehensive Hashimoto's plan. I like really love inositol for this. I found that it did make a difference when I was using just vitamin D and selenium. It was like I'm not seeing any significant changes. But when I
Mhm.
added in the inositol for patients, things start to move more consistently. And
Yeah.
Hmm,
like I see consistent results with that. So, like across the board, most of my patients will respond well to that. And we
cool.
do see, so there is a newer study that uses all three and comparatively to them on their own. And there does seem to be like a synergistic effect. So when we're using all three of them together, the benefits are greater than if we're using just one or two of them.
Mhm. Okay. I found the same with myo-inositol. I mean, I had always taken selenium, vitamin D,
Yeah.
zinc. Those were like the ones I used to stick with. And then I think it was you. I think it might have been through the Thyroid Academy that I learned about myo-inositol, and game changer for me. So
Yeah.
confidently was able to prescribe that to patients, and I did. I found the same thing, that it's not even just a lab change, but like a symptom change too, which is
Hmm,
obviously
Yeah,
always the goal.
absolutely. And I find
um mhm.
inositol a little bit more effective for TSH management as well. So I see more
Yeah.
TSH improvements when inositol is part of the treatment
Yeah.
plan. So I will
Mhm.
use it outside of Hashimoto's for those like just hypothyroid patients where we're trying to
Yeah.
kind of optimize things. The
Mhm.
level of inositol in the thyroid tissue in those with Hashimoto's and hypothyroidism is actually less than the levels of inositol in healthy thyroid tissue, which I just think
hmm,
is cool. Um, and the
Yeah.
research is like it's there. It's like early days, but it's something I've seen so much clinical success with. Like I'm
Yeah.
all about it.
Yeah, I love it. It's a shame that we have these wonderful tools, and then we have the thyroid support complexes that don't have this.
yeah. I know, that's
I
what
mean,
I always thought
Yeah,
about because there's so
yeah.
many, like, at health food stores, it's just all the complexes, and you wouldn't you like, if you go into a health food store and, like, say they have, like, a shelf for thyroid, you're not gonna have just inositol there, you're gonna have all of the complexes, right? So,
yeah.
maybe that's a new marketing thing you guys have to do.
Honestly.
Tell me about it. Tell me
Yeah,
about it.
Yeah.
I mean, like every
Um,
supplement company has a thyroid complex out there.
for
We've
sure.
yeah.
all prescribed one probably, back in the day.
Mhm.
But I like when I was using that in practice, like 10 years ago, like it did nothing. Like patients didn't
Mm,
Sure.
necessarily feel better. Nothing changed
Mhm.
on lab work. Sometimes things got worse. And I was like, I'm some are better than others, but I think
Yeah.
it has a very, very small application. Like I would
Mhm.
consider a thyroid complex for somebody who is maybe non Hashimoto, so non autoimmune, and has a
Mhm.
very restricted diet, either
Right.
just like a very lack of nutrients in general, or they're
mm,
vegan, or like something like that, where we don't think they're getting the basic ingredients to make thyroid hormones, iodine, tyrosines,
Yeah.
things like that, because that's what like is most of a thyroid support complex. Like we've got the
Yeah.
backbones, but in Hashimoto's, like we have those ingredients. Our thyroid just can't use them properly because the tissue is
mm.
Yeah.
too. So I think we have to switch
Mhm.
from like providing ingredients to helping the thyroid feel better so it can use the
Mhm.
ingredients more effectively.
Right.
Mhm. Before we move on from the supplements,
Yeah.
iodine.
Yes.
Yes.
Can you touch on that quickly? Because I'm tired of getting yelled at. I need you to back me up here, Katie.
Yeah, so iodine's really interesting. And I think it's another one that we have seen like both ends of the spectrums. Like either iodine is like if you have iodine, you're gonna like either set your thyroid on fire or you absolutely need high dose iodine and this is the only thing that's going to help your Hashimoto's disease. And like I have
Hmm.
seen every version of it like from one end to the other. When we're looking at the literature, little less
Hmm.
sexy of a result,
Yep.
but we see that iodine intake over and above 150 micrograms can increase inflammation in the thyroid gland. So can worsen autoimmune thyroid conditions, both Hashimoto's
Hmm.
and Graves'. There's again some caveats. I find that it's less of an issue if we're like preloading people with a lot of thyroid antioxidants, so things like selenium and zinc and inositol. That
Yep.
impact might be a little bit less. And there's also these really cool like genetic differences that we see. So some people are more tolerable to varying levels of iodine and perhaps like high levels of iodine, and some people
Hmm.
are not. So they think that's more related to where our basically our ancestors resided. So people that
Yeah.
ancestors were around the sea and were having lots of seafood and sea vegetables, like those people can tolerate higher levels of iodine without it causing major dysfunction. But the
Hmm.
inland like prairie dwellers, like there is no room for these higher levels of iodine levels. um, so it's really fascinating. There's so many different areas where it would factor into like our conversation and whether or not a person needs it. But the most common thing I'm doing in practice is making sure people are not getting too much. So I'm trying to make sure we're not exceeding that RDA of 150, micrograms a day, basically,
Yeah. Okay. I'm
which
glad
is
we had that conversation.
yeah,
Yeah.
really easy to do. So like
Yeah.
iodized salt, there's 70
Hmm.
micrograms in like a quarter of a teaspoon. A
Yeah.
multivitamin usually has 150 micrograms. A
Mm.
thyroid
Yeah.
support could have anywhere from 300 to 700 micrograms.
My
And
Yeah.
gosh.
then our like just dietary intake. So there's iodine
Yeah.
in eggs, dairy, like a lot of the foods that we're eating commonly. Obviously, our
Hmm.
fish and our seafood and things like algae and like seaweed based stuff. Um,
Hmm.
so it is quite reasonable to think that in a normal North American non restricted diet, we're getting plenty
Hmm.
through our diet alone and we don't need to supplement. And if we do supplement, like 100 micrograms, like you
Yeah.
do not need a lot. You do not need a lot.
Yeah. Okay. Good. I'm glad we covered that.
Mhm.
Okay. Another big question.
Yeah.
Should people with Hashimoto's go gluten free?
Oh man. So yeah, another hot topic for sure. And this is where I think another one like we've seen some sort of some sort of conclusion made in some area of the research and it's been like blown out of proportion and extrapolated to like the
Yeah.
entire thyroid population. So I've seen this everywhere. Like so many thyroid blogs will say if you have Hashimoto's or thyroid condition, you need to avoid gluten.
Yeah.
Um, our body produces antibodies against gluten, and that looks like our thyroid tissue. So if you're eating
Yeah.
gluten, you're basically destroying your thyroid tissue. Um, and when I went back and like sourcing, like going back through like where are they sourcing this from? Where's their reference? Like
Yeah.
going deep, like half the time they're just referencing other websites that say the same thing.
Yeah.
So when I finally
Yeah.
found the original source, it came from a study that investigated gluten removal in patients with Hashimoto's and celiac disease.
Yeah.
So
Mm.
in these patients, if you have celiac and Hashimoto's and you take out gluten, that makes a big difference. and it will
Yes.
absolutely reduce your thyroid antibodies and the inflammation on your thyroid gland. But
Mhm.
my problem is that we've used that, and we have like said everybody with Hashimoto's needs to be
Yeah.
gluten free, when I don't think personally that's the case. I think again, this is like patient by patient. If you've
Yeah.
taken out gluten and you feel better, I'm cool with that. Like, let's make
Yeah.
sure you're still getting all the things you need in terms of carbohydrates and fibers and stuff like that. But if you feel,
Mhm.
I was gluten free for many, many years. Like, that's, I'm
Mhm.
cool with that.
Yeah.
But a lot of people come in to my office like removing gluten and being scared to have any.
Mhm.
Like, it's going to set them back. They're
Mhm.
fearful about it, or they're terrified I'm going to tell them they have to be gluten free.
Yeah.
And the amount of times patients are like, oh my gosh, like I'm so relieved. Like, you think I could have like a little bit of sourdough? And I'm like, yes,
Yeah.
girl.
Yes.
Like, go wild and have a slice of sourdough.
Yeah.
Yeah. Yeah. It's interesting because I mean, even when I was in clinic, there was some supervisors that would say, like, if you have a hypothyroid or Hashimoto's patient, like visit one, they have to cut out gluten. Like they
Yeah.
have to do it. So I think it's just interesting seeing like the different approaches. And I think like that could go down a whole other path. Like what if you're putting someone on an elimination diet, step one, without talking to them or going through all these steps, like how are you setting them up for success in the future, right? But
100%. And how many
yeah.
patients have walked into an ND office and first visit been told you need to go gluten and dairy free, and they
Yeah,
never come back?
exactly.
Because
Like,
Yeah.
that is, I've done it. Like, I have been to a naturopath. It was like, you need to go gluten and dairy free. Like,
Yeah.
first off, no conversation. And I was like, I'm not coming. Like, I,
no.
Yeah.
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 It's a lot.
it's really hard for patients to make dietary changes. It's hard for
Mhm.
anyone to make dietary changes. And
Mhm.
when we're pulling out whole food groups, like more
Yeah.
than one at a time, it's personally, I think it's bad medicine, and
Mhm.
it's not encouraging the type of relationship we want with our patients, or the
Yeah.
relationship that they have with food,
Yeah.
which is a whole other topic.
Oh,
Yeah.
100%. What is a myth about thyroid health that drives you absolutely crazy? If you could pick one.
Oh, I mean, I feel
You
like
only
we've
get one.
talked. Yeah, can I only pick one? I feel like we've talked about a lot of them today, like the reverse T3, the gluten. One of my other, like that like I see and annoys me is like the whole optimal T3 thing.
Mm.
So that really annoys me as a myth. And I also, and we can talk more in depth if you want. I also have that like old school myth of like you have to treat the adrenals before the thyroid. That also
Oh
really
God.
grinds my
Oh,
gears.
okay.
I don't know
Haven't
Yeah.
if you
heard of
guys
that
have
one.
that, but
I've seen that one.
yeah, it
Okay.
comes across a lot. And again, this is another scenario where we've looked at a very specific niched population and have extrapolated it to like all thyroid. So if you have someone who
Right.
has Addison's disease, which means you have a lack of cortisol, this
Yeah.
is like serious condition that needs to be medicated, you need to be treated properly. If you have an
Mhm.
untreated Addison's patient and you give them thyroid medication, that person's going to the hospital. Like, it causes
Yeah.
an adrenal crisis. So
Yeah.
I think we've taken that like very unique situation and we've been like,
Yeah.
you just have to treat adrenals before thyroid. Like, that's what we should do.
Okay. I see.
Yeah.
And where it really doesn't come from, like, for the vast majority of patients, like, just treat their thyroid, man. Like, if that's what's wrong,
Yeah.
like, you don't have to start with the adrenals.
Yeah. Like
Mhm.
let's get
Yeah.
people feeling better in the first
Yeah,
visit.
and delay the
Mhm.
process if,
Yeah.
the adrenals. I mean, I think that adrenal fatigue, maybe you guys have already done an episode on this, and I think you
Yes.
probably have.
Yeah.
So refer to that episode, everybody. But that whole concept, we have to change our language around that and what we're really doing for people when we talk
Mhm.
about
Yeah. Yeah. I was actually given that exact advice. I was told I have to fix my adrenal fatigue before I take thyroid medication.
Oh
that.
wow.
Right? So silly. So silly. Like, do you
Yeah.
have Addison's disease? Then you're fine.
No.
You're good.
Wow. Okay, and last, if you could give one empowering message to anyone struggling with low thyroid or Hashimoto's, what would it be? It can get very overwhelming on the online space.
So overwhelming. And I think the big message would be, as much as you can, try not to doctor yourself. Try
Mm,
not to overconsume information because it is so readily accessible and there's so much bad information out there that can make us feel even more overwhelmed,
Yeah.
and confused because half the time they conflict one another. So, like, when patients come in,
yep.
I'm like, that's my job now. Like, you need to let me do my job.
Mhm.
You need to give me this part of it.
Yeah.
Like, you don't have to be researching supplements and
Yep.
researching what else we should do next. Like, let me
Mm-hmm.
take that on. And half the time they're like,
Yeah.
oh, okay, like, because it's a problem in the thyroid space because you really like thyroid patients have to be their own advocate because they
Yeah.
don't get good treatment often in a
Mhm.
conventional space and they are left looking for more options. And like, I get that, like, deeply, I
Yeah.
understand that. But you do like work with someone who's going to know your case, and be your advocate for you, and be your little
Mhm.
researcher on the weekends, and they can figure
Yep.
out what's best for you so that you can just live your life and enjoy it and not be, going down Instagram rabbit holes about avoiding lectins.
Oh gosh. We
Yep.
just talked about that today with someone.
Yeah.
I love it. I've actually never heard that advice given, and I am going to use that with patients. That's really, really true. They're coming
Mm-hmm.
to you for a reason,
Yep.
right? Like, release the control.
Yes, like, let me take this off your plate. Like, this is mine now,
Mhm.
and your job is to, do your homework. But
Yeah.
like, the big stuff, like, let me do it. Like, that's what you're paying
Yeah.
me to do. That's what you're here for. Let me
Yep.
take that for you. And most
Yep.
people meet that with like such a sense of relief that they're like, okay,
Yeah.
like, this person is actually going to take care of me. And they know
Yeah.
what
Mm-hmm.
they're talking about, right? So you want to, of
Mhm.
course, find someone who has some, continuing ed, who works with
Mhm.
alongside me in some capacity, and who knows
Yep.
what they're doing when it comes to thyroid health. Because, yeah, it's a mixed
Yeah.
bag.
It
Mm-hmm.
definitely is. Speaking of a mixed bag, so we're going to end off our episode with rapid fire.
Oh Lord,
And
okay.
it's funny. It's funny because I already know your answer to all of these, but that makes it like so much more fun because they're
Okay,
they're
cool.
good.
Love it.
But I'm gonna give you statements that we see online all the time. I know you see them constantly. You're going to say myth, truth, or it depends.
Okay,
Okay.
got it.
Okay. You can heal your thyroid with Hashimoto's and come off medication.
It depends.
Medication can lower antibodies in Hashimoto's.
True.
I think that might be shocking to people.
Yeah.
Dairy can worsen thyroid antibodies.
It depends, but mostly false. Mostly
Okay.
a myth.
NDT or natural desiccated thyroid is a better option than levothyroxine for most patients.
It depends.
You should be gluten free with Hashimoto's. You know that
Myth.
one. Cruciferous vegetables can worsen
Oh,
hypothyroidism.
myth.
I hate that one.
Let's just put that one to bed, everybody, okay? Like,
God,
yeah, we're not living in 1850
Awful.
anymore.
Right.
seriously. Oh, since when are we worrying about broccoli?
Yeah.
Yeah.
A thyroid support supplement can play a powerful role in healing Hashimoto's.
Myth.
Powerful role.
Okay, my favorite. This is going to be the best one to
Okay.
end us off. 3 Brazil nuts a day is a good way to get your selenium in.
Oh, myth. And so many patients come in doing that, and
I'm sure,
I'm
yeah.
like, they're doing it because they think it's the right thing, and like, it could have enough selenium, but it also could not, and it could have way too
Yeah.
much, and like, let's just use what we know works.
Mm-hmm.
Mm-hmm. Mm-hmm.
Yeah.
100%.
No.
Well, thank you so much for coming on. I learned so much during this episode. We really appreciate your time today. We know you're very busy. And again, we wanted to wait to have a thyroid episode with you on today. So, again, thank you so much for coming on. Can you
Oh,
let our listeners know where they can find you, where they can book with you, all of that information?
yeah. So I'm on Instagram at your.thyroid.nd. It's the best place to find me in terms of content and information. You can find booking links through there. I co own a practice in Barrie, Ontario, and see patients regularly. I also head up the Thyroid Academy. So, this is a learning platform for health professionals, mostly NDs. So, there are a lot of specific courses around prescribing and Hashimoto's, and then like probably 20 to 30 other modules surrounding thyroid health. So, if you're looking
Amazing.
for answers, that's where you can find them.
All right. I'm heading to that website now. Thank you so much for coming on.
Oh, thanks for
Thank
having me. That
you.
was a really fun conversation.